Today's webinar is part of a series of webinars being co-hosted by the Chronic Disease Prevention Alliance of Canada, or CDPAC, and the Public Health Agency of Canada's Centre for Chronic Disease Prevention. The webinar is entitled An Integrated Approach to Preventive Public Health Interventions in Early Childhood, from Biology to Implementation. And we're extremely pleased to be co-hosting this webinar today, which will highlight recently published information about the introduction and evaluation of the Nurse-Family Partnership Program in Canada. My name is Bill Callery, Manager of Programs and Knowledge Exchange at CDPAC. And for those who aren't familiar with CDPAC, we're a network of many of Canada's largest national health charities and professional health organizations, sharing a common vision for an integrated system of research, surveillance, policies, and programs for maintaining health and preventing chronic disease in Canada. And as usual, we have our website and our social media coordinates at the bottom, so connect with us. And you can also find past webinars as well as upcoming webinars on our website. So on behalf of CDPAC and our co-host, the Public Health Agency of Canada, I'd like to wish you a very warm welcome to today's webinar. Really pleased to be presenting our Q&A moderator, Lil Tonmar, as well as our presenters, Susan Jack and Andrea Gonzalez. So Lil Tonmar is going to be helping collect the questions as we go through the webinar, and she'll be asking the questions to the presenters at the end. Lil Tonmar is a researcher with the Public Health Agency of Canada. Her current research interests involve the epidemiology of child maltreatment, reporting practices to child welfare, health outcomes after child maltreatment, and the use of research evidence in policy development. Susan Jack is an associate professor, School of Nursing at McMaster University. She has over 20 years of clinical, administrative, and research experience in the field of public health. Dr. Susan Jack's program of research is focused on developing and evaluating community approaches for the prevention of family violence, and she's one of the leads responsible for adapting and evaluating the Nurse-Family Partnership Program that we'll hear about today. Finally, Andrea Gonzalez is also at McMaster University, an assistant professor in the Department of Psychiatry and Behavioral Neurosciences, and cross-appointed to Clinical Epidemiology and Biostatistics and the MINDS Neuroscience Program at McMaster. She's also a member of the Offord Center for Child Studies. Andrea's research focuses on the developmental consequences of child maltreatment across the lifespan, the intergenerational transmission of violence, and developing evidence-based interventions for the prevention of child maltreatment and its sequelae. She is co-investigator of the BC Healthy Connections project and a nominated principal applicant of the Healthy Foundation study. So extremely pleased to have our two presenters today, as well as Lil Tomlin helping us out with questions and discussion. And without further ado, I will pass it over to Susan to get us started.
Hi, everyone, and thank you for the opportunity. This is Andrea Gonzalez. I'm going to kickstart the talk today to present to you on an integrated approach to preventative public health interventions in early childhood, from biology to implementation. So our webinar objectives today are to provide an introduction to the concept of biological embedding and measurement of biological factors within an intervention context. It's one of the aspects of the project in British Columbia, to provide an overview of the Nurse-Family Partnership, which is a public health intervention, to outline the process for adapting, piloting, and evaluating complex public health interventions, and to highlight the collaborative policy practice research partnerships that are undertaken in public health evaluations of this nature. So we know that the building blocks for healthy development are established early on. Although genes are the main driver behind brain development, environmental influences fine-tune brain development. And the major ingredient in this process is the interaction between infants and their caregivers. So infants naturally engage and initiate interactions through their gestures, facial expressions, cries, and babbles. And when caregivers are responsive in terms of their timing, the content of their responsiveness, and appropriateness, it strengthens connections in the infant's brain, which support development of the own child's social development and communication abilities. And the absence of appropriate caregiving, either through unreliable or inappropriate responses, can lead to disparities in health, learning, and behavior. So I'm just going to provide a bit of an overview about the biological development that occurs very early in life, because the nurse-family partnership, which is the intervention that we're going to focus on later on, starts prenatally and continues postnatally. So the basic foundation of the brain is constructed through ongoing processes that begin before birth and continues into adulthood. But in the first 3 years of life, there are major changes in the brain. In the first year, the brain doubles in size, and this occurs through a proliferation period where 700 new neural connections are made every second in the first few years of life. The excess of neural connections in the first 3 years makes the brain especially responsive to external input, so environmental influences. And during this period, the brain actually captures experiences more efficiently. After this period of rapid proliferation in the brain, brain connections are reduced through a process called pruning, so that the brain circuits can become more efficient. So our experiences and environment dictate which circuits get used more and grow stronger, and connections which grow stronger and more permanent, whereas ones that are used less tend to fade away. And this is sometimes referred to the concept of use it or lose it. So that by age 3, the brain has reached approximately 85% of its adult volume. So connections in the brain are built in a prescribed order, with later, more complex circuits built upon earlier, simpler circuits. In parallel with these brain changes, there are corresponding changes in childhood learning sensitivities that occur around the same timelines. So more basic functions are formed first, followed by more complex functions. So for example, sensory pathways like those used for basic vision and hearing are the first to develop, followed by early language skills, and then higher cognitive functions. So although the brain remains plastic for much longer than we originally believed, for example, the prefrontal cortex continues to develop well into our 20s, it's easier for the brain to respond more efficiently to experience and the environment early on compared to later on. So for example, when you think of language, although we can learn a second language later on in life, in adulthood, it's much easier for us to learn languages very early in development compared to later on. So both children and adults may be able to make up for missed experiences later in life, but it becomes more challenging and more difficult. So what happens when the foundation is at risk or compromised? All children need stimulation and nurturance for healthy development, and because the brain adapts to its environment through these first set of years, it will adapt to a negative environment just as readily as it adapts to a positive environment. So when we think of stress, we generally equate stress with being bad. However, not all stress is bad. There are 3 types of stress. There's positive stress, which involves brief increases in heart rate and mild elevation in stress hormones. And it's the kind of stress which is associated with normative and predictive everyday events in early childhood. So things like the child meeting a new person, being in a strange place for the first time, being left at daycare, getting a vaccination, having their favorite toy taken away by another child, or learning how to share. And it's good stress because one is learning how to deal with stress. Tolerable stress is longer lasting and can potentially be serious threats such as an illness or loss of a loved one or a serious injury. And it can be challenging to children because it leads to increase in physiological stress responses. However, adult caregivers help the child regulate the stress and help the child return to baseline. So even if they experience stress for a prolonged period, the adult caregiver is helping the child regulate their stress and to bring it back to normal levels. Toxic stress, however, is when stress levels go up and they stay high. And this type of stress is typically associated with conditions of chronic adversity, such as exposure to family violence, child maltreatment, and family economic hardship. What is characteristic of toxic stress is that there is not an available caregiver there to help the child regulate their stress levels. And it's called toxic stress because the brain can't tolerate high levels of stress for long periods of time. So converging evidence from neuroscience, genetics, and molecular biology are helping us to better understand the long-term effects of toxic stress. In the next few slides, I'm going to provide a very quick overview of some of the known effects of family violence on biological outcomes. And I focus specifically on family violence as a toxic stressor because it is our area of research. However, similar effects can be seen with other types of early adversity, such as maternal mental health or poverty in early childhood. So the most studied system is the hypothalamic pituitary adrenal axis, which is our stress system. And there's quite a bit of research out there that indicates that early life adversity or exposure to childhood maltreatment is related to dysregulation of the HPA axis. And this has been studied both in children and adults, where they've looked at individuals' responses to stress themselves or their diurnal activity, so the course of their stress levels throughout the day. And what they found is that there are disruptions to the way that the system functions. More recently, because of its close ties to the stress system and to health outcomes, people have become more interested in immune system functioning. And there are a number of studies which now show that childhood maltreatment is related to elevation of inflammatory markers, such as C-reactive protein. This is important because chronic low-grade inflammation is linked to a number of conditions, including traditional psychiatric disorders such as depression and substance abuse, as well as allergic, metabolic, cardiovascular, and rheumatic diseases later in life. Imaging research is showing that there are structural changes to the brain, both in terms of the size and volume of brain areas, and functional changes, so the way that our brain responds to various types of stimuli, in the brains of individuals that are exposed to childhood maltreatment. For example, research has shown that there's a decrease in volume of the cerebellum, which is an area that plays a role in emotion processing and fear conditioning in maltreated individuals compared to non-maltreated individuals. And some studies have reported smaller prefrontal volumes in maltreated individuals. The prefrontal cortex is a key area for cognitive abilities and executive processing, and it's also an area which is vulnerable to high levels of stress hormones. Studies have also shown that childhood maltreatment affects our DNA. So telomeres are the end of chromosomes that basically function to protect the DNA from damage following replication. With every cell division, telomeres naturally shorten in length. However, a number of studies have shown that individuals maltreated as children have shorter telomere lengths compared to non-maltreated children or individuals. The lengths of telomeres are proposed as a measure of disease risk, so it's associated with later risk of cardiovascular disease and biological aging. So researchers have interpreted some of these shortening of telomere lengths as an indication that biologically maltreated individuals as adults are showing a greater biological aging. So most recently, studies have shown that exposure to childhood maltreatment can lead to epigenetic modifications. Although it's beyond the scope of this talk, basically what this means is that early adverse environments can change the way our genes work and function. So it doesn't change the DNA or the gene itself, but our environmental experiences can turn genes on or off to affect the way that the genes function, things like protein production. And this is one explanation of how early environmental factors get under the skin to affect later health and disease. So why is this important in the context of family violence or early adversity more largely? Based on 2008 data from the Canadian Incidence Study, rates of investigated maltreatment and substantiated maltreatment are highest for infants that are less than 1 year of age. This data should really give us pause because based on the previous slides, we know that these children are at a critical point developmentally in terms of their brain development, as well as their basic functioning. We know that changes in brain structure and chemical activity caused by child maltreatment can have a wide variety of effects on the individual's behavioral, social, and emotional functioning and health outcomes across the lifespan. So for example, we know that exposure to family violence in infancy is associated with difficulties in affect regulation, attachment, growth, and it leads to developmental delays. This continues throughout childhood with a greater risk of psychopathology, as well as academic failure and poor peer relations. And then in adolescence and early adulthood, it's related to conduct disorders, risk-taking behaviors, recurrent victimization, both as a perpetrator and a victim. And then later in adulthood, it's associated with a number of mental health and physical health outcomes, as well as parenting difficulties, including the abuse of one's own offspring. So just to recap, there are a number of experiences which can influence health outcomes, either positively or negatively. These experiences interact with the children's genetic predisposition to create either physiological adaptations when development is healthy or disruptions when it's not. And there are two ways that are proposed that early experiences get built into the body. The first is from cumulative wear and tear on biological systems caused by recurring adversity. And we know from our own experience that risk factors don't tend to occur in isolation, that they tend to cluster together. And so there's a clustering together of risk factors as well as a chronic recurrence over time. The second way that early experiences can get built into the body is through biological embedding. And this is the process by which early experiences get under the skin and alter the human biology and development. So one example of that is epigenetic modifications, which I spoke to in an earlier slide. So essentially, this biodevelopmental framework puts together a framework of how early experience weaves its way into neural and biological structures of the child to impact later developmental outcomes. So how do we prevent this? Our team adopts a three-tiered approach, first to prevent family violence before it occurs, or after it has occurred, to prevent reoccurrence and to prevent any associated impairments. The major focus of our current work is on prevention before occurrence. And you can either take a universal or a targeted approach for prevention. Universal means that it's available to everyone, regardless of risk status, or a targeted approach by where one identifies at-risk populations. And this is what the Nurse-Family Partnership is, a targeted preventative intervention.
Great. Thank you, Andrea. This is Susan Jack, and I'm going to take a few minutes to ground all of you in the components of the Nurse-Family Partnership, which, as Andrea identified, is a targeted public health intervention. I'm then both of us will then briefly describe how this program is being adapted and evaluated in Canada. The Nurse-Family Partnership Program of Home Visitation was developed by Dr. David Olds, and Dr. Olds is a psychologist and a professor of pediatrics at the University of Colorado, Denver. This targeted public health intervention uses public health nurses to home visit and deliver support to vulnerable pregnant women and first-time mothers. The therapeutic relationship that develops between the public health nurse, the client, and her family provides the foundation for achieving three important goals. One, to support mothers to have a healthy pregnancy. Two, to support the development of parenting capacity and skills that will lead to improvements in child health and development. And three, to empower mothers and families to become more economically self-sufficient. There are many different models of home visitation in Canada, and home visitation programs may vary on quite a few variables, including client eligibility characteristics, the time of enrollment, the length of the intervention, and home visitor qualifications. In this home visitation program, the NFP, or the Nurse-Family Partnership, we've already identified that it is a targeted home visitation program that has demonstrated the most significant benefits for mothers and children at greatest risk. So eligibility in this program is limited to young, first-time mothers who are socially and economically disadvantaged. To maximize the impact of this intervention on fetal and child development, pregnant women are enrolled early in pregnancy and no later than the end of the 28th week of pregnancy. By starting early in pregnancy, the nurse then has time to develop a strong relationship with the mother and also has time to work on improving the mother's own health and therefore the health of the newborn. Once a family is enrolled in the program, the public health nurse continues to visit regularly until the child's second birthday. Nurses, and again in Canada specifically public health nurses, with a minimum of a baccalaureate degree in nursing, deliver the intervention. Nurses as interventionists bring a high level of knowledge and skills, as well as critical thinking skills that enable them to assess and develop tailored plans of care for clients who are often experiencing multiple health or social crises in their lives, such as homelessness, poverty, mental illness, exposure to all types of violence across the lifespan, or substance misuse. Public health agencies that contract to implement the Nurse-Family Partnership agree to implement the program with fidelity to 18 core model elements. When this program is implemented with fidelity, then families and communities can have a high level of confidence that the results will be comparable to those measured in research. In the United States, the Nurse-Family Partnership has been evaluated for over 35 years across 3 separate randomized controlled trials. The first trial was conducted in Elmira, New York, with a sample of 400 low-income, primarily Caucasian families. Then the trial was replicated in Memphis, Tennessee, with a sample of 1,138 low-income, primarily African-American families. The final trial to evaluate the effectiveness of NFP in different contexts was conducted in Denver, Colorado, with a sample of 735 families. The Denver trial also systematically examined the impact of the program when delivered by paraprofessionals and by nurses. However, the results from the Denver trial indicate that when trained in the NFP model, paraprofessionals produced small effects that rarely achieve statistical or clinical significance. Nurses produce significant effects on a wide range of maternal and child outcomes. And for most outcomes on which either paraprofessional or nurses produced significant effects, the paraprofessionals typically had effects that were about half the size of those produced by nurses. In the United States, the level of proven effectiveness demonstrated is unsurpassed in evidence-based home visitation programs. The program effects that have the strongest evidentiary foundations have been found in at least 2 of the 3 trials I just briefly described. Consistent program effects include improved prenatal health, fewer childhood injuries, fewer subsequent pregnancies, increased intervals between births, increased maternal employment, and improved school readiness. Most remarkably about this program is its long-term benefits to improving the health and well-being of families over multiple generations. The evaluators of this program in the U.S. continue to follow up with families from the original trials to determine the effect of the intervention on outcomes across the lifespan. Most notably, in a follow-up with participants from the Memphis study, 20 years after the intervention, there were reductions in all causes of mortality among nurse home-visited mothers and reductions in preventable cause mortality among their firstborn children. The NFP not only benefits families, but it benefits communities as well. An analysis conducted in 2005 in the United States by the RAND Corporation found a net benefit to society of approximately $34,000 for high-risk family service. That is a return of approximately $5.70 for each dollar invested in this public health prevention program. As a public health intervention, long-term savings are also accrued across multiple sectors. For example, again in a follow-up of the Memphis trial among children at age 12 years, over that 12-year period, for nurse home visited mothers compared to controls, governments spent less per year on food assistance programs, Medicaid, and social assistance. These benefits and cost savings, however, are greatest when the program is delivered to the most vulnerable families and specifically to mothers with low psychological resources. One of the most notable impacts of this program is its effect on preventing child abuse and neglect. The evidentiary standard for the NFP program are among the strongest available for preventive interventions. NFP is most often cited as the most effective intervention to prevent child abuse and neglect, which contributes to childhood injury. And from a public health perspective, injuries are a leading cause of death among young children. In the first trial, which was conducted in Elmira, New York, there was a 48% reduction on state-verified rates of child abuse and neglect. There was also a 56% relative reduction in emergency department visits for injuries and ingestions during the child's second year of life. It is important to note, though, that in this Elmira trial, those benefits related to the reduction in rates of child abuse and neglect were attenuated when women were exposed to moderate or severe levels of intimate partner violence. Given the strong evidence in support of NFP, there has been great interest internationally to adapt and evaluate the NFP in other societies. In the Netherlands, where their version of NFP is called Voorzorg, the results of their RCT also demonstrated a positive effect on rates of child abuse. In their study, 223 participants were assigned to the control group and 237 were assigned to the intervention group. 3 years after birth, 19% of the children in the control group had reports to Child Protection Services, whereas the 11% of children in the intervention group with Child Protection Service files was significantly lower. So here's another point for you, or allow all of you to interact. So I have a question to pose to all of you. Given this base of evidence and given the extensive research that has been conducted to evaluate the effectiveness of NFP in the United States, as well as other countries internationally, why would it be necessary to conduct another trial of effectiveness of the Nurse-Family Partnership in Canada? So I'm going to give you a few minutes to either write on the slide or to type your answer into the poll.
So Bill here, Susan, I don't think you can see the responses, but I'm able to open them up here. So maybe I'll read a few out so people can hear others' thoughts. So one point for special populations such as rural and remote First Nations and Inuit. Another point to inform program and policy decisions. Contextual concerns, different policy and funding mechanisms that may influence effectiveness. Canada has socialized medicine, so service as usual is different. Interventions are context dependent. Determinants of health may differ from country to country. We have a different healthcare system, different cultural backgrounds in Canada, different political systems, social service supports. So lots of different responses here, different public health infrastructure. They have different healthcare and child support systems.
Excellent. Thank you. And thank you to all of you who have responded and have provided such articulate and accurate responses. If we live in a society that values implementing evidence-based interventions, then logically we need to understand that we cannot take an intervention that has been evaluated in another context and determined to be effectiveness and just assume that we will see the similar benefits or effects in a completely different context. And so many of you have identified what are some of those variations in our context here in Canada. So thank you for providing those perspectives. This is exactly why we've seen that given the level of evidence that has been attributed to the NFP, there has been extensive interest, of course, all over the world, in countries and societies outside of the U.S., with a desire to immediately implement the NFP. However, Dr. Olds, who again is the developer of the NFP, coordinates all the international program of research and coordinates evaluation and international evaluations outside of the U.S. through his team and colleagues at the Prevention Research Center for Family and Child Health at the University of Colorado, Denver. And as all of you have already identified, in countries outside of the U.S., such as Canada, there really is considerable geographic, demographic, socioeconomic, public policy, nursing workforce, and healthcare system variations. And therefore, we really cannot assume that the impact of the NFP that has been seen in the U.S. trials will be seen in our Canadian context. As such, Dr. Olds has developed a 4-phase model for adapting and evaluating the NFP in countries or societies outside of the United States. In this 4-phase model, the first stage is about adaptation, and that involves exploring what adaptations are needed to deliver the program in the local context while still ensuring fidelity to the 18 core elements of the NFP program. Once the model has been adapted, international sites are then required to conduct feasibility and acceptability pilot studies. And these are initial small-scale assessment and implementation studies to inform whatever additional program adaptations may be needed to meet the needs in this new country's context. Once feasibility and acceptability have been determined, then evaluation teams can move to the third phase, which is the conduct of a randomized controlled trial to expand and test or evaluate the intervention to determine the effectiveness of this program on certain prescribed outcomes in this new context. Depending on the results of the randomized controlled trial in any one country, the fourth step would then be continued refinement of the implementation model and expansion and moving to a stage of full implementation. So in Canada, we began the process of adapting the U.S. NFP model in 2008 through a highly collaborative partnership between McMaster University and Hamilton Public Health Services. The visit-to-visit guidelines and home visit content and activities were adapted between members of the research team and the NFP public health nurses and supervisors at Hamilton Public Health Services. And we made many adaptations to the U.S. work. Some of these adaptations were to integrate Canadian standards of practice and best practice guidelines, to augment materials to meet local needs and priority issues. For example, in Canada, it was a priority for public health nurses to meet all recommendations from the baby-friendly initiatives to promote breastfeeding. And we also used it as an opportunity to integrate new NFP innovations. So one such innovation that was embedded into the Canadian NFP visit-to-visit guidelines was a nursing intervention to identify and respond to intimate partner violence. Given the impact of exposure to IPV, a form of child maltreatment, on both maternal and child health outcomes, this was a priority enhancement, and it allowed for the embedding of assessment procedures developed specifically for NFP nurses to allow women to safely discuss their experiences of abuse, and in turn for NFP nurses to develop, in collaboration with clients, tailored plans of care to increase safety, a client's sense of self-efficacy, her awareness about the impact of her IPV exposure on her health outcomes and the health outcomes of her child, and to increase her access and use of supportive community services. After working collaboratively to make adaptations to the visit-to-visit guidelines, we then conducted a pilot study with this team of 6 public health nurses and 1 supervisor, providing NFP to 108 women in Hamilton, Ontario. And our pilot studies were conducted from 2008 to 2012. The results from the pilot study demonstrated that it was feasible to provide the NFP program through public health units in Canada. It was feasible to have public health nurses deliver the intervention. We found that we were able to receive appropriate referrals from community partners in a timely fashion, to successfully enroll eligible participants, and to home visit this targeted population of young, low-income, first-time mothers. Comprehensive NFP program data were also collected via Nurse-Family Partnership nursing assessment forms that elicited systematic information on each mother's health status and health behaviors. A process to collect client outcome data by the research team was also successfully implemented. In conjunction with this feasibility study, a qualitative case study was conducted to determine overall acceptability of this public health intervention to a wide range of stakeholders. Overall, mothers who participated in the home visits identified the NFP as an acceptable early intervention public health initiative. At the organizational level, this intervention created an environment where public health nurses could deliver holistic nursing care at their full scope of practice, develop in-depth therapeutic relationships with clients, and have the infrastructure, resources, and materials to assess and intervene with clients who, again, experience multiple complex health and social conditions. In addition, community professionals responsible for referring to the program identified that this program addressed an important gap in service delivery for this population. So conducting pilot studies of feasibility and acceptability then sets the foundation for conducting trials of effectiveness.
Thanks, Susan. So it's Andrea again. So to date, there have been 2 other international evaluations of the Nurse-Family Partnership where results have been published. One is in the Netherlands and a second in England. And they differ from one another in terms of their sample size, participant inclusion criteria, and outcomes. So in the Netherlands, their sample size was 460 participants. Their inclusion criteria included less than 26 years of age, less than 26 8-week gestation, first-time pregnancy, low education, and then 1 of 9 additional risk factors. And what they found was that the Nurse-Family Partnership reduced prenatal nicotine use. It had no impact on infant birth weight, but it improved breastfeeding initiation and duration. It reduced child protection reports. It reduced intimate partner violence exposure and improved child behavior outcomes at age 3, internalizing behavior problems only. In England, the sample size was 1,645 participants. The inclusion criteria was that women had to be less than 19 years of age, less than 25 weeks gestation, with a first-time pregnancy. And what they just found was the Nurse-Family Partnership resulted in increases in child language development at age 2, increases in maternal self-efficacy, but no impact on prenatal smoking, infant birth weight, breastfeeding initiation, no impact on child emergency room or hospital admissions for all causes, or child injuries by age 2. They also didn't find an impact on subsequent pregnancies at 2 years postpartum. So now I'm going to turn to the Canadian evaluation of the Nurse-Family Partnership, the BC Healthy Connections Project, which was launched in 2013. So the BC Healthy Connections Project is a randomized controlled trial evaluating the effectiveness of the Nurse-Family Partnership compared with existing services in British Columbia. The eligibility criteria include women who are aged 24 years or younger, first-time parent, less than 28 weeks gestation at the time of enrollment, and able to provide informed consent in English, and experiencing socioeconomic disadvantage. We're enrolling approximately 1,000 mothers, and in addition to the randomized control trial or the evaluation, there's a concurrent process evaluation, which Susan will tell you more about. And right now it's being conducted in 5 of the 6 regional health authorities across BC. So the main outcome indicators and measures were explicitly chosen to enable replication of some of the more robust findings from the U.S. trials, while also addressing indicators of salience for BC policymaking. So in Canada, our evaluation is unique in that there is a concurrent process evaluation and a biological evaluation, which is embedded within the BCHCP. Some of the main indicators for the trial, the primary indicator is child health, so child injuries from birth to age 2 years, and this will come from Ministry of Health data on community and outpatient emergency and hospital healthcare encounters. And our secondary indicators include prenatal tobacco and alcohol use from maternal self-report, child cognitive development at age 2 years, and for this we're using a standardized test called the Bailey Scales of Infant Development. It's not based on maternal self-report. And we'll be measuring child behavior at age 2 using the child behavior checklist, so looking at internalizing and externalizing problems, and subsequent pregnancies at 2 years postpartum based on maternal self-report. So now I'm going to just quickly tell you about the biological evaluation of the BCHCP, the Healthy Foundation Study. We received competitive funding from the Canadian Institutes for Health Research to embed the biological evaluation of the NFP within the trial. And following the biodevelopmental framework that I showed you earlier, we are specifically looking at whether or not the NFP has an effect on infant biological functions. So we're looking at infant stress regulation, infant immune function, and epigenetic modifications in the infant. Whether the NFP has an impact on maternal prenatal stress and other risk factors which the NFP is known to affect, things like maternal substance use, maternal financial resources, maternal mental health, and maternal exposure to intimate partner violence, and whether the NFP changes these factors and these changes are associated with changes in the infant's biology across the first 2 years of life. And finally, our aim is to look at whether or not changes in infant biological function explain the association between the impact of the NFP on infant health. So we know from previous trials that the NFP does affect infant language and socio-emotional functioning. So we're really trying to see whether or not one of the mechanisms of change is through biology. And we follow the same timeline of data collection as the BCHCP. So women are recruited into the project. They're given their baseline assessment. We collect hair from the mothers to look at stress physiological markers. Women are either randomized into the intervention to the NFP or existing services. And then we collect hair again from the mothers at 2 months. These are proxy measures of stress that the infant would be exposed to in utero. And then we collect saliva and buccal swabs from the infants across the first 2 years of life to look at some of the biological indicators. And one of the reasons that we think this is quite innovative is because the inclusion of biomarkers within the preventative intervention context is quite unique. It's never been done within the context of the nurse-family partnership before. And it may provide a scientific explanation for specific types of health outcomes that we see later on. But these may be early indicators of those later outcomes. It may also provide a basis for assessing individual susceptibility to adverse effects of environmental exposure. It can make available objective indicators for assessing intervention effects, so we're not looking just at behavioral effects and maternal self-reports. And it will help increase leverage to advocate for preventative initiatives later on.
Thanks, Andrea. So the BC Healthy Connections project is comprised of 3 studies. So Andrea has already identified and discussed 2 of those studies, the Healthy Foundation study and the randomized controlled trial to evaluate effectiveness. The 3rd study that follows under the umbrella of the BC Healthy Connections project is a process evaluation. So not only are we evaluating NFP within the context of Canada, but when we look to the province of BC, where the trial is being conducted, it's being delivered and implemented across 5 unique health authorities in BC. And what we are discovering is that each of these health authorities is unique in its geography, population characteristics, and pre-existing culture of partnerships and collaborations, which are so essential to support NFP at the community level. So this level of complexity creates challenges for evaluating both the effectiveness of interventions and for understanding how causal mechanisms of interventions may influence intended outcomes. So we really believe that one of the most unique components of the BC Healthy Connections project is this parallel conduct of the process evaluation, which has been funded through the Public Health Agency of Canada. The process evaluation has been designed to help us answer questions about how NFP is being implemented and delivered, and will eventually inform our understanding of why this program succeeds or has potential limitations across the different health authorities and different contexts. Data from this process evaluation will also contribute to our knowledge on how the NFP model must be adapted to meet the needs of a diverse population, to those living in either urban or rural or remote communities most specifically. We will also be focusing on exploring how NFP public health nurses identify and then address issues related to child welfare involvement, intimate partner violence, and mental health, including substance misuse. Furthermore, data from the process evaluation will be used to eventually inform the development of Canadian-specific model elements and also inform the development of a Canadian model of nurse and supervisor education. Parallel conduct of both an RCT to measure the effectiveness of NFP in BC and the process evaluation to understand how and why this intervention works is, as I mentioned, very unique. So inclusion of this process evaluation also allows us to collect data to share with key policy and implementation partners about emerging implementation successes and challenges. This is a mixed method study that is, again, being conducted in the 5 participating health authorities. As a mixed method study, we are purposely collecting both qualitative data and quantitative data. We are exploring nurses, supervisors, managers, and directors' experiences of delivering NFP through the conduct of in-depth interviews, either in person, telephone, or focus group interviews every 6 months. We're also collecting data about the types of supervisory activities occurring in each health authority through supervision documents maintained by NFP supervisors and quantitative data about program delivery through provincial fidelity data. The implementation and evaluation of a public health intervention, such as NFP, delivered across an entire province is a really complex process that requires the close collaboration between multiple stakeholders. The BC Healthy Connections project, with its 3 main studies, works in very close collaboration with senior policymakers in the BC Ministries of Health and Children and Family Development, and with the 4 BC health authorities, Fraser Health, Interior Health, Island Health, and Vancouver Coastal Health, that are involved in recruiting individuals for the randomized controlled trial. A 5th health authority, Northern Health, also participates in the collaboration, but not in the RCT, just the process evaluation. Furthermore, we have key individuals located within each of the health authorities, as well as the BC Ministry of Health, who play important and significant lead roles in implementation of this intervention, as well as delivery of the education for nurses and supervisors. Finally, the 3rd group of stakeholders are those of us who are the researchers evaluating this program. So here's just a list of just some of the key policy, practice, and research partners involved in this complex endeavor. So we've really uncovered that to facilitate this work, a strong policy, practice, research partnership is so essential, and that it's really important to develop this at the very early stages of any project of this nature. We are also pleased to identify that because of the early development of partnerships and the very thoughtful procedures gone into developing governance structures, that these partnerships are active and continue to date. The benefits of this type of active collaboration are many, but just to highlight a few is that by engaging in policy, practice, and research partnerships, it allows us to, or it facilitates shared ownership of problems and a commitment to finding solutions for these problems as we work to implement and evaluate NFP. These partnerships have also enabled the research partners, specifically Simon Fraser University, to develop data sharing agreements with the BC Ministries of Health and as well as the Ministry of Children and Family Development, so that we can collect data such as emergency room and primary care visits. These partnerships also allow the process evaluation team to share real-time data through written communiques on topics that emerge through the interviews and focus groups. So in summary, we support that primary prevention through public health is essential to prevent child maltreatment and to improve health outcomes across the lifespan. The BC Healthy Connections Project is one of the first interventions to incorporate a cell-to-society approach, examining biological mechanisms within a preventive intervention. We would also like to endorse that it is important to adapt and evaluate the effectiveness of interventions such as NFP prior to rushing to implementation of programs or interventions in new contexts. And finally, work of this scope is most successfully managed within strong policy, practice, and research collaboration. And finally, work of this scope is only possible through partnership and funding through multiple sources. So at this time, I would like to acknowledge the key funders for all of this work that is occurring within BC and across Canada, specifically the BC Ministry of Health with support from the BC Ministry of Children and Family Development, the health authorities. We acknowledge the support for the process evaluation from the Public Health Agency of Canada, and the Healthy Foundation study that Dr. Gonzalez spoke to has been funded through a competitive grant from the Canadian Institute of Health Research. So we have half an hour left of our webinar here. And while we have been speaking to you, Dr. Léo Tonmier has been making note of your many brilliant and thoughtful questions that have been added to the chat group. So we will turn the microphone over to Lil to moderate a question and answer session, and Andrea and I will do our best to answer your questions.
Thank you, Susan and Andrea. An excellent presentation. I think we all felt that we learned a lot. You have highlighted some unique research being conducted in BC, addressing public health intervention in early childhood development. As you said, we have received many questions, and we will try to answer as many as possible. So I will start with a general question for either of you. When will the results be available in Canada?
Thank you. That's a great question. So the BCHCP was launched in 2013, and we expect recruitment to wrap up next year in 2016. And as indicated, a number of our main outcome measures occur at child age 2. So we have to wait for those children to grow up. So I think we would expect the first results to be coming out in 2019 from some of the main indicator data and outcome measures.
Excellent. So Susan, a basic question, what is considered a young mother in British Columbia?
Okay. So for eligibility in the NFP, one of the main model elements is to identify mothers at greatest social and economic risk. And age is often used as a variable to identify mothers of highest risk. So what is a young mother? In BC, within the context of a randomized controlled trial, mothers are eligible to be enrolled into the trial if they are less than 24 years old and meet other eligibility criteria that Andrea identified. Mothers who are less than 19 years of age are automatically eligible. So that is within the context of the randomized controlled trial and the eligibility criteria that was set up for a trial. In other settings where NFP is being piloted or implemented, there may be different decisions around what is a young mother or what is age. So for example, in Hamilton, Ontario, where we piloted NFP for feasibility and acceptability, the age criteria for eligibility was mothers less than 21.
Slightly related to this question, Susan, it was asked what low psychological resources mean.
Oh.
So the question asks further, does that include mild intellectual disability or low insight or social isolation or?
I think in the original trials, it wasn't just about intellectual disability. It included a number of factors, including maternal self-efficacy and some of the cognitive processes of the mom, but not necessarily intelligence per se. But off the top of my head, I can't recall. Yeah.
There's come in a couple, thank you so much. There come in a couple of other questions regarding measures. And one of those talks about smoking.
Okay. So how is cigarette smoking targeted? So how is the question like how is it targeted? How do nurses address the behavior, or how is prenatal exposure to cigarette measured in the trial?
I think it's the exposure part.
Okay. So in the trials in the United States, it was measured through biological measures of cotinine. So it was not self-report. So mothers were not self-reporting how many cigarettes they smoked, but there was actual measures of their cotinine. And then in terms of, if we're also looking at how is cigarette smoking directly targeted within the intervention, it is a key focus for the nurses' work prenatally. And all of the public health nurses who deliver the NFP receive extensive advanced education to deliver this model of care, and all of the nurses receive additional education in skills such as motivational interviewing. So not only are they working with clients to provide information and education about harms of behaviors such as smoking, but nurses are active interventionists to address behavior changes amongst clients through using strategies like motivational interviewing.
Excellent. Andrea, I think there's a question for you how language development was measured or is measured.
Is measured?
Yes.
So in the original trials, it was measured through a behavioral measure. It was measured through the preschool language scale. Other international trials have relied on maternal self-report measures. In the British Columbia trial, we will be using the Bailey Infant Scale of Development, and it measures multiple domains of infant functioning. So we're going to be measuring cognitive functioning, motor development, and language, and it actually breaks down into both receptive and expressive language measures, and that's going to be administered by in a standardized way through a trainer.
Thank you very much. There was a discussion about, meanwhile you were talking, there were several questions about paraprofessionals, how they were, how you judge someone to be a paraprofessional in the U.S. Then there were questions about the applicability of the comparison to Canada. And should we look at, for instance, a group like social workers? Could they give this intervention? I'm summarizing a couple of questions here and comments. So if you would like to comment, one of you would like to comment on that?
Sure. It's an excellent question, a complex question, a thoughtful question, and a question that has been asked by clinicians, policymakers, researchers across multiple countries. In home visitation, there is often great debate around who should be the interventionist or the provider of services. And in the late 80s and early 90s, there were many programs in the United States that moved from professional models of home visitation to using paraprofessionals. So individuals who may not have a professional designation, such as social worker or registered nurse. So in Canada, where there are paraprofessional home visitation programs, the individuals that are hired as paraprofessionals sometimes are lay home visitors, mothers who have had the experience of being a mother in a high-risk context, or a paraprofessional such as someone who has a early childhood development diploma. So across different contexts, paraprofessionals can be defined in different ways. Because of these questions were emerging in the U.S. around the potential benefits that a paraprofessional could have in influencing health outcomes amongst moms and children, it is my understanding that that is one of the reasons that Dr. Olds included that arm in the Denver trial. And in the Denver trial, nurses and paraprofessionals were not directly compared. Instead, paraprofessionals were educated through the NFP model and compared to controls, and they were intensely supervised by, I believe, a master's trained social worker. And then a second arm of the trial had nurses delivering NFP compared to controls. As I identified, there were few statistically significant effects that were achieved by the paraprofessionals, and in cases where they did demonstrate some benefits, the effect size were twice as great for the nurses. Again, it's my understanding that based on the results of that trial, Dr. Olds stuck to his decision to keep one of the core model elements of the NFP, that it be delivered by registered nurses with a minimum of a baccalaureate degree. And in the 70s, when Dr. Olds was delivering this program, he very purposefully selected nurses as the interventionists. For many different reasons. One, there is a long history of public health nurses and community health nurses delivering home visiting services focused on maternal and child health care to vulnerable populations, both in the United States and Canada. So there is that pre-existing practice and history in both societies. Second, nurses are continually identified as a trusted professional. And in the work that we do with very vulnerable families, having a public health nurse come into your home often has less stigma as compared to having other professionals into your home, such as a child welfare worker. The third reason, and this is one that I strongly believe in, is the acuity of these clients is so high. For many of these young mothers, they may be living in conditions where they have unstable housing. Many of these mothers have grown up themselves in and out of foster care. They're living in poverty. Some of them may have experienced exposure to different types of violence across their lives, or they are just coping with day-to-day survival. On top of this context, these are pregnant women and new mothers who have many questions about their health and the health of their children. So nurses are really identified as someone who comes with the knowledge and skills to address these issues in a very therapeutic way through a social determinant of health lens, through a health equity lens, and have the knowledge and skills to address these issues. There are many different, again, when we think of the acuity of these clients, it is important to ensure that there is a professional that has the level of skill to intervene with them to help address their needs.
There is a question that just came in about Aboriginal or Indigenous people, and I wonder if any one of you want to respond.
Okay. Again, another excellent question. And again, if the question is, has the NFP program been adapted or evaluated for its effectiveness in Indigenous communities? So in the BC Healthy Connections project in BC, there's the ongoing conversation and development of collaboration with different Indigenous communities. At this current time, women who live on traditional lands are not eligible for enrollment in the randomized controlled trial. However, if there are Aboriginal women living in urban centers and they meet the eligibility criteria and consent to being in the trial, then they are eligible to receive NFP if they are randomized to the intervention arm. So that's our current context in Canada. This is a priority issue, and in Canada we have not yet had the opportunity to look at the model, to look at the program materials, and adapt them specifically for Indigenous communities. However, the great part of being a member of the international NFP community, and NFP is currently being adapted and evaluated in many societies, including the United Kingdom, Norway, the Netherlands, and Australia. And in Australia, as part of Prime Minister Rudd's reconciliation to Aboriginal populations in Australia, the NFP was offered as a program for Indigenous communities. And it is my understanding that Australia is doing work and has been doing work since about 2008, 2009 to adapt the program for Indigenous populations in Australia. And one of the unique adaptations that they have in Australia is that in conjunction with the nurse doing the home visits, there is also a community elder who joins the nurse on the home visits as a liaison between the NFP team and the Aboriginal family. There's also work being done through the Prevention Research Center at the University of Colorado, again led by Dr. Olds, to look at adaptations to the model in the United States with tribal communities in the northern U.S. and the Dakotas.
That was a thorough answer, Susan. Thank you so much. We have gotten a really practical question, and Andrea, I will turn to you. What would a caregiver be doing to help this child regulate its own stress?
Oh, that's a great question. Thank you. One of the key factors about caregiving across species, not only in humans, is that the caregiver, the maternal figure, is a buffer between the environment and the infant's stress and developing physiology. So we found in our own work, not within the context of an intervention or the nurse-family partnership, but with a community sample, that really what is critical is is responsive and sensitive caregiving across the first few years of life. So we looked at infants who were 15 and 16 months of age, and we did home visits with the mothers, assessed their parental capabilities, so their maternal sensitivity, and we exposed the infants to two types of stressors. One was a toy frustration task, so it was more about emotion regulation and how did the infant deal with frustration. And a second stressor was done in the lab in the context of the mom leaving the infant alone or with a stranger for various periods of time, and we looked at physiological stress in the infants under these two conditions. And what we found was that infants who had mothers who were more responsive and more sensitive actually had more flexible stress systems. So when they needed to mount a stress response in the context of a stressful situation, they were able to, and then were able to return to baseline, where with frustration they didn't have to mount that kind of response. Whereas infants with less sensitive and responsive mothers really did not regulate their stress very well, and their stress system really didn't differentiate across systems. So really it's that early caregiving environment, the mom or the caregiver being very responsive and sensitive to the infant's cues and being effective. I think that is one of the key regulators.
Thank you very much, Andrea. There can be, building a little bit, you talked about education, Susan, and what training is provided. We have gotten a question about how you ensure uniformity in the training across nurses.
Okay. So it's an excellent question about education. Again, one of the core model elements of the NFP program is that all public health nurses and supervisors who are employed to deliver NFP are required to complete NFP-specific education. So we know that public health nurses hired into this program come with a great depth of knowledge around their public health nursing competencies and a lot of expertise and content related to topics like child development, behavior change, breastfeeding. But the question is then around how do we ensure informity and what type of education is provided to nurses and supervisors. And the advanced education is really about grounding nurses and supervisors in the unique components of NFP. In the very early education sessions, there is grounding in what are the principles of NFP, what are the outcomes associated with the NFP program, a deeper understanding of the theoretical underpinnings of the program. So nurses examine and discuss theories such as attachment theory, self-efficacy theory, maternal role. I'm just trying to think of some of the different the ecological theory. So they really grounded in the theoretical components. Then there is also time taken to enhance nurses' skills related to activities such as motivational interviewing, how to conduct specific assessments and develop tailored interventions for responding to family violence, education around how to promote positive parenting interactions. So really the education is focused on the development of new knowledge and a very specific set of advanced practice skills. Now the second part of your question is quite intriguing. How do we promote uniformity of the delivery of the intervention? So all of the nurses will receive a very consistent and ongoing supportive education system. And right now it's being expertly delivered by Donna Jepson, who is the provincial coordinator of NFP in BC and a team of amazing supervisors in BC. So the education is uniform, But then how do we trust that nurses are delivering a consistent intervention in practice? Well, that's what makes this a complex public health intervention. Unlike the administration of a medication where we can control ingredients and dose, we can't in this type of public health intervention. And that's part of the nature of the NFP intervention, is that nurses and clients work collaboratively to identify what are maternal goals, what is mother's main needs, what are identified concerns, and that the nurse and the client work collaboratively together to meet the client's needs within the context of the home visit. The NFP model also has six domains of content, so things focused on physical health, maternal role, the types of relationships that the client has with her family, and community support. So there's 6 domains of content that nurses are required to address on every home visit. So I think that that's one component of the model that ensures some uniformity, but it can't ever be achieved because every home visit will be so different.
Thank you, Susan. I think we have time for one more question, and that relates to exposure to intimate partner violence. I've heard that it has not always been successful in the U.S. to reduce intimate partner violence. Are there any ways we are addressing that topic?
Okay. So thank you, Lil, for that question. As I identified earlier, in the first trial in Elmira, it was identified that for mothers who are experiencing intimate partner violence, the benefits related to reducing child abuse and neglect were attenuated in this program. So given that and the high incidence of women exposed to IPV in this targeted population, it was identified a need to enhance the program to address intimate partner violence. So there's been an ongoing program of research in the U.S. since about 2009, 2010 to specifically develop an education model for nurses to increase their knowledge and skills about how to identify and address clients' exposure to violence, as well as the development of an intervention and a clinical pathway to help nurses make decisions on how to support women exposed to this type of violence.
Thank you, Susan. This has been very, very informative. So thank you for presenting to us. Before you get a chance to say some closing comments and we hand over to Bill, I just wanted to say last week there was a special issue where both Dr. Jack and Dr. Gonzalez contributed to the Public Health Agency's journal called Health Promotion and Chronic Disease Prevention, where many of the issues they talked about today are discussed. Would you like to say any closing remarks?
Well, just thank you for the invitation to come present on the webinar, and for everyone organizing it, and for everyone who attended and all your thoughtful questions and comments that we've seen on the chat. Just thank you.
And I would agree. Thank you to Lil for moderating and asking the thoughtful questions. I know there were so many questions that we didn't get a chance to answer, and I would like to thank all of you listening. This is the most interactive webinar I've been a part of, and seeing how engaged everyone is in the chat. And I would love the opportunity to engage and talk to many of you who've posted very thoughtful questions. We don't have the time to do that today, and nor the mechanism to do it. So you'll see on the screen all of our email addresses. If you would like to continue to dialogue or have responses to some of the questions that we weren't able to answer, please feel free to email Lil or myself, Susan Jack, or Andrea Gonzalez at any time so we can continue this dialogue. So thank you so much for your interest in this, what we feel is a very important public health prevention intervention.
Bill, over to you.
Great, thanks very much. Well, yes, I'll just echo the thanks to our attendees for attending, but also the really thoughtful questions. And of course, a huge thanks to Lil for your excellent job moderating our questions and discussion, and Dr. Susan Jack and Dr. Andrea Gonzalez for presenting. So that's really fascinating, and I'm really pleased to hear that you're willing to engage with some of our participants. I know they'll be happy to hear that. I shouldn't forget as well to again thank the Public Health Agency and the team behind the planning of this webinar, particularly Denise Harper, who's been really fabulous in terms of kind of rallying us all together and handling a lot of the logistics behind the webinar. So thanks again, and I think that's it. Maybe I'll say goodbye to everyone now and thank everyone and have a great day.